All right, welcome to On the Sideline. I'm your host, Jeff Holden. Today, we got Big O.
How y'all doing today?
And we got United Regional's special guests with us today. We have the outpatient rehab manager, Miss Shari Craig.
Glad to be here. Thank you for having me.
Yes, ma'am. And Windthorst's own sports trainer, Mr. Tim Thomas.
Thanks for being...
Did I say that right? Sports trainer? Athletic trainer.
trainer.
Okay, sorry, yeah. Same thing, right? Same thing.
Close.
Yeah. So today we got United Regional is on the show. We've got we had head athletic trainer Jeremy Woodward come in and kind of give us the overall on the field, kind of like the first step for injuries. Then we had Dr. Dozier come in, and he did a lot, talk to us about the surgical side. And now we want to focus, I think, today is more so on the rehabilitation side. So the three facets, we got the injury on the field, we got the surgery, which hopefully that doesn't always end up being the case, and then the rehab. So if you guys want to, we'll just let you introduce yourselves to everybody, and then we'll go from there. Ladies first, we'll start with you.
Okay. My name is Shari Craig. I am the manager of outpatient rehab at United Regional. I've been there for almost 7 years, and I have found that I've worked in various facets of rehab, but this seems to be my favorite. I get to see lots of patients walk through their rehab and go back to their activity more so than what I did in my other facets. So what we're here to talk about today is injuries that are common, specifically to football. So we're going to see some ACL tears, meniscus tears, some tendonitis, which tends to be constant during all of these athletes' life, and then some strains and sprains throughout their practice. Some of these are going to be operative, some of these are going to be non-operative, and so we can be there rehab on either side of that.
Very good, very good. And Tim?
Tim Thomas. I've been at United Regional for 10 years. Been an athletic trainer for Windthorst for 10 years. And started off as a PT tech going through college. So started off doing a lot of rehab. That's kind of my foundation, is the rehab side of that.
So how'd you end up in Windthorst?
It's a contract.
Okay. So they planted you there?
Kind of, yes.
Yeah.
Can I say something on the air? Like, you look like you were born in Windthorst. Because, like, all the people in Windthorst, like, has your look. Like, it's
right.
like, so you belong in Windthorst. There was United Regionals did an excellent job of placing you out there. Because if I guarantee if we lined all the coaches up, nobody would knew you were the trainer. They would have thought you were a coach.
Right.
So, congratulations on being out there. I know you fit in well out there. A bunch of good guys out there in
There is
Windthorst.
a bunch of good guys, for sure.
Yeah, so we'll just jump right into it. Like I mentioned, we had the field, we had the surgery, and now we have rehab. Do one of y'all just want to touch on the common scene football injuries? Which one of y'all do you want to go? Tim, I guess
Sure.
Since you're the trainer, you're
You
actually
bet.
on the field, so
Yep.
let's go with that.
And I feel like that's kind of the trainers always kind of talk about what's going to be the trend this year. It seems like it's either ACLs or shoulder injuries or fractures. And it just kind of varies. And you might get a mix of all of them. But a lot of them are ACL tears, especially with the turf now being more common. ACL tears are more common now. And this year I've seen a lot of shoulder injuries and fractures. So just kind of, and hopefully I won't see any ACL tears because that's a season-ending injury. So shoulder sprains, wrist fractures, it's just been very common this year.
So since you brought it up, I'm happy that you brought it up actually too, because not saying that you're an older guy, but a lot of the older guys, they swear that, and I believe them too now that I'm paying attention to it more. I don't want schools to go away from it because it looks nice, but I've heard it a lot now that you are more prone of risk with the turf and the different things. Just not only just the ACL and those type of injuries, but just injuries as a whole because of how I guess the impact with the turf is not as as cushion as most people would think that it is. So, I mean, I know that's probably something in your years that you've been doing it now. Do you think that ACL and these type of injuries, and this is for both of you guys, have increased a lot? What would you say, if you could give a percentage, what would be the percentage of increase you think, since most schools now are going to turf?
I would say probably about 60%. Yeah, it's quite a bit. If you don't pick your feet up and move your feet, it's going to happen. Because that turf grabs you, and if you get lazy, then something's going to happen. And I also think that as the turf gets older and harder, that rubber that's in there that keeps it soft, that over time that the sun just makes it so hard and brittle. If you don't replace it soon enough, then you see more injuries like concussions and stuff like that. So more foot injuries.
I think that's a good answer too. And the reason I like that, and you said the turf will grab you, we call it the turf monster.
Absolutely.
I mean, you see kids all the time just running and they call them non-contact injuries, where a kid's just running and next thing you know he's down, and you be like, oh no, and then they're like, yeah, torn ACL. I'm like, what? He didn't even get hit. Yes. So it's just one of those things where I think parents need to kind of be aware of that, especially with the support, the type of cleats and things that they're wearing, understanding the type of turf first and foremost that your school has. I see a lot of kids going to it looks cool for the soccer cleats and different things like that, but especially in the game of football, I just think having a little bit more of a supportive cleat. This is just my opinion, y'all. I'm not a professional. Probably could help eliminate some of that stuff. So,
according to your wife, you'll be a professional after this, right?
Yeah, I am. Shout out.
And this type of turf we have now is a whole lot better than the AstroTurf that we used to have years ago. That was like a carpet. That was horrible. That was absolutely horrible.
Yeah. So, I guess there's two different types of injuries, right? The operative end up being surgical, and then the non-operative. Shari, do you mind going over just like some of the operative protocols and, like the rehab goals and milestones and stuff like that?
Sure. So the doctors are very particular about how quickly we progress their athletes to make sure that we're being as safe as we can. So, ultimately our first goal is to restore that range of motion. Then we're going to start working on their strength. And then we're going to gradually move them back into those activities. But we're going to make sure that they can perform each of those activities in isolation, and then we'll start putting them together. But ultimately, they have to be able to go through a non-contact practice before they can go back, and then a full contact practice. Then we look at returning them to their sport. So it's very stepwise and protected throughout the whole process.
So question about that. So when I'm hearing that, I like to try to tie the knot. So, of course, you have the trainer out there on Friday night. He's the first person to see the kid when the kid goes down. First one probably to hear a parent's like, you don't know what you're talking about. There's nothing wrong. You're just saying that. I'm like, no, I'm not saying that. I'm just being honest with what I think. So then the next step is that the kid comes in for, I guess, would be to be assessed outside of what the trainer happens. And then let's say the kid does have an injury where he has to be operated. So then he meets, the doctor operates on him. And then after the operation, he steps over into the rehab side of things. But in the rehab side of things, what you were saying, I noticed the first thing that you said, that the doctors don't want you guys to speed up the process. They want it to be handled a certain type of way. So in my understanding is, from how I'm hearing this, is you have the trainers who can't sign off but have to be a part of the rehab process. You have the rehab people who can't sign off that has to be a part of the rehab process, just to ultimately go back to the doctor who's trusting the trainers and the rehab process to get an answer to make sure things are done the right way to get the kid back on the field or the court or wherever they're playing. Is that kind of how the process goes?
Absolutely. That physician who is doing that surgery or following that injury, he's in ultimate control. We're backing him up. It's a team effort. There's communication, collaboration through all levels, but he can't do his job if we don't do ours, and we definitely can't do ours if he's not behind us. So any surgeon will tell you once they've done their surgery, that was 10% of the recovery. And the rest of it falls on rehab, athletic trainers, and the patient to do their part to make sure that they are able to restore that function.
Okay.
Yeah, so it actually sounds like there may be 4 parts, because you got the the actual trainer, then you got the surgeon, if that goes that way, rehab, and then
Back
actually
to trainer. We're kind of the bookends of that.
and then also playing factor the patient, like you said, and the patient's
Absolutely.
parents, because most of these patients right now are high school athletes, so it's a
So I know
it's a
one of
full
the-
circle, and if somebody messes up, it could really damage the whole thing and have to start over, I guess. And I guess that's why you guys are so important.
One of the things we do run into is parents and athletes who want to go back too quickly. And we know that with certain injuries, specifically ACLs, if we send them back into full contact sport too early, their increased risk for re-tearing that, even if it's a graft that's been put in. And so we want to delay that as long as we can to make sure they've got ultimate healing and then put them back in the situation.
So you touched on it briefly. So you said the doctor's in control. He wants to know what's going on. Is that, and I'm assuming that's like a protocol, right? Like
Yes.
each doctor has, so say it's an ACL tear. Post-surgery, 3 weeks, they start doing this. And then 5 weeks, they start doing that. I mean, it's all lined out like
Exactly.
that, right?
So typically we see them anywhere from 2 to 5 days after their surgery. They're going to come into rehab and get started because we want to get them in there and restore that range of motion really quickly. But yes, it's a stepwise process, and each surgeon may have a different protocol, but also each surgery. So if it's an ACL and he uses a cadaver graft, it's going to be treated very differently than if he uses a hamstring tendon or a bone from the patella to the patellar tendon to the tibia. It's treated different.
I learned
So
right
all
there.
that.
All that information right there.
So there's probably 3 other different grafts that they could use, but those are the most common.
Most common.
But yeah, each one we have to protect a different portion of the leg to let it heal, but also let that graft set in.
Okay, so quick question. What is the general time frame from surgery to release back to play for an ACL injury?
About 9 to 12 months.
9 to 12
Yeah.
months. And that's all dependent on the patient.
Anything less than 9, you're at increased
You're
risk
at
for tearing it again.
time.
What if you're Adrian Peterson? As y'all heard, he came back like, I don't remember his time frame, but it was like
It was fast.
ridiculously fast.
Yes.
They have access to a little bit more than we do
Maybe.
Yes, they
at
do.
United Regional and
Hey,
at Windthorst.
hey,
So
Yes, for
Well.
sure.
You never know.
But I think sometimes with the injuries is like you were saying, it's about the patients plays a huge part in the willingness to listen. I've seen kids come out with ACL injuries and their willingness to want to get back to the field kind of helped them out a little bit because they took their rehab. I hate to say it serious versus, just kind of picking and choosing because rehabbing from an ACL injury is not easy. You're going to go through some things. The hardest part is what you just said is that 2 to 5 days right after surgery. I'm like, the first kid I seen through, I was like, I couldn't do it. I was like, there's no way because he showed, like, they were explaining what they were doing in those 2. I said, how? You just had surgery. And they were like, basically what you're saying, if you don't do it then, it basically kind of sets you back a little bit. So just
Every day you wait probably reduces the.
absolutely. So we're going to bring them in day 2 or 3. We're going to start some electrical stimulation on that quad, get it firing back again. We want to make sure we get their range of motion for extension first. Then we'll gradually get that flexion back. But by 2 weeks, we're putting on some blood flow restriction to make sure that we can really exercise those muscles, but without having to do much bending or straightening of the knee, we can give them a good workout.
Yeah, I think you touched briefly on the return to play criteria, but I think it's important that maybe we discuss it a little bit more and maybe go into more detail. So, I guess generally speaking, for both an ACL tear and an operative shoulder surgery, what is some of the key criteria for return back to play for these kids from the operative side?
Go ahead.
From my standpoint, it's being like bilateral strength and range of motion. If you're strong on the right side, the operative side, you got to be just as strong as the left side. So if there's a weakness there that we detect, then it's not ready to go. On the functional side of that, if they can't run, without a limp or start and stop easily without pain, those are all like red flags for us. doing some 5-10-5 agility work, stuff like that. If they're not able to do that without a quick stop, without pain, or you can kind of tell they're gimping on it a little bit, then it's time to keep on working on it.
Right.
So again, there's a list of tests that
Yes.
they have to pass in order to,
Return
and
to
that's
play.
and that's something you guys would sign off. But then the doctor, obviously, he's going to look at it as
Sure,
well and take going to trust your judgment and all that because you guys have such a professional working relationship. But
Yes.
he's going to also probably take a look
Absolutely.
and then finally say, okay, you're ready.
Yes, and a lot of times we try to go into the appointment with the athlete when they go see the doctor. When it gets to that point, and that way we can just say, hey, this is what he's doing. This is how he looks. He's having some pain here, some problems here.
So you're advocating for the player as well.
Sure,
Okay.
Absolutely.
Very
So one of the things, Tim touched on it. We're looking for side to side. It's got to be about 85 to 90%. So it can't have more than about a 15% discrepancy, or that athlete's not ready to return. It's got to be full functioning. And the other portion of that is you got to look at the mental side of it. So they have to be in the right mindset. They have to be willing to tell you when they're hurting. When they may go home and have, sharp pains in that muscle or that joint, and they've got to be willing to come back and tell you, hey, this was what happened, and we have to work back through that.
So I'm sure you guys get the macho, nothing hurts me, but keep in mind, kids that think they can fake the pain, they're professionals. They're going to be able to tell, even if you're not telling them the truth, if you're in pain. So,
Yes.
yeah.
So does it matter? And this is something I wanted to get on the air too, because I think I'm one of the parents probably that think this, but does it matter the position or the process is the same? So some people think, oh, well, a running back's process is a little bit different than an offensive lineman or a linebacker, or they think the position means that, oh, I play this position so my time frame speeds up. So can we kind of explain that the time frame? I'm asking. So the time frame is the time frame, basically, no matter the position.
Absolutely. And a lot of linemen have more ACL tears than running backs or linebackers, just because the position they're in, they're getting hit from behind, from the running back, and just getting landed on from the guy next to him. And so, I think the position doesn't matter at all. It's got to be.
The activities they do may be different because that linebacker doesn't need to be throwing like a quarterback,
Right.
but the time frame is going to stay the same depending on what the process was we went through.
So I think, and this is good, they're going to go to the rehab facility
Yes.
and they're going to get us a general workout, but then probably the athletic trainer is going to say, okay, you're the quarterback.
Right.
I need to put you through this, this, and this.
Right.
And you got to be able to pass that.
Yeah.
Whenever they could just be like, okay, general, not general, but,
We do the specific activities as well. In fact, we're going to be the ones who try it out with them first most of the time and say, okay, they've been able to do this pain-free. You can go ahead and include this in your workout at school. It's just a collaboration.
yeah.
And we also have a lot of room on the field to work with them too.
Yeah. Compared to the,
compared to the gym.
CAO is pretty big. It's a pretty big building.
Yes,
Yeah,
it
it's
is.
very nice. We enjoy it.
So let us take a quick break real quick, get a word from our sponsors, and we'll be back in just a minute.
At Orthopedics Express, our primary focus is delivering exceptional care to patients with orthopedic injuries, such as sprains, strains, broken bones, and joint pain. You'll receive the expert care you need when you need it most. Simply walk in or schedule an appointment through MyChart. Located inside the Center for Advanced Orthopedics, Orthopedics Express is your fast track to orthopedic care.
All right. We're back. Thank you again to United Regional for being our sponsor. We have Tim and Shari still on the show. We talked about the operative side of the rehab. Now let's talk about the non-operative. So this is probably more common than the operative, thank goodness. So what are some things in the non-operative side that we would like to mention? I guess we'll go with you for now, Tim.
A lot of times the MCL sprains, if it's just an MCL and no meniscus involved, that's a non-operative injury, and it's a pretty easy rehab, wouldn't you say, Sherry?
the most part.
Compared to an ACL. It has a lot of blood flow, so it heals really, really well. Sprains, shoulder sprains, those are another good thing that we can work on with the PTs and get them back.
So I had a question. There's another injury you can get in your knee. It's not an ACL. It's not an MCL. It's like
Runner's knee.
LCL or the patellar tendonitis.
Yeah, it's just like, but it's kind of like a week-to-week type injury is what I was told. Like it's one of those injuries where you kind of monitor it. You kind of got to go through some type of rehab and stuff with it, but it's something that some kids handle it a little bit different than others. Some kids play on it actually, and then some don't. But it is. But what exactly is that injury? The reason I'm asking because I know a kid that recently suffered from it, and he just been playing on it. I'm like, bro, you a monster. I couldn't have anything with my knee. I'd be like, I'm done.
So I think you're talking about Osgood-Schlatters disease in the patellar tendon. It's usually in adolescence, and it's very painful, but you can play with it. But it's just one of those agging and nagging, painful. Every time you run, jump, it's just painful in the patellar tendon.
Can you work past it, or is it something that's like for life?
You can.
Okay.
You're scarred for life because the callus that forms on that patellar tendon is there for a lifetime. But
okay,
yeah, but it is a very painful injury, and it's one of those. A lot of people call it growing pains, and but it's.
We can see that
it's
tendonitis or tendinosis in pretty much any tendon in the body, and I don't know about you, Tim, but I see it a lot, specifically in the smaller towns where kids are playing more sports. They're playing year round. They're constantly coming back with a tendinosis and just kind of working their way around the hip. Sometimes they come in, they have hip flexor, then it's gluteal tendon, then they come back and it's the adductor, and it's just a constant barrage on their body because they're involved year round and they're just
Non-stop.
pounding it.
And a lot of them play two sports at a time. They play fall ball and plus their school sport. So
I've got one right now who's playing football and soccer, and
it's tough.
we just can't get past it. So.
right, and a lot of it too is lack of flexibility. A lot of kids do not stretch at all, and even our older athletes don't stretch at all. The ones that are playing pickleball and golfing 3-4 times a week.
Exactly. And so for those diagnoses, we're looking at kind of trying to control that inflammation, trying to get control of the pain, and then restoring, like Tim said, that range of motion so that they can be more successful when they go back. But if we don't take care of those issues, then it's just going to be an ongoing thing.
What's some things that you guys use to be able to kind of help with those non-operative particular things?
Yeah, we use a lot of manual therapy. So we don't usually call it massage. It's soft tissue work. It might be our thumb, it might be our elbow. We might have a tool in our hand. We have it's called radial pressure wave therapy. It sounds like a jackhammer when you're in the gym. It's very effective at starting a small inflammatory process in the body so that the body comes back and says, oh, we need to do some more work here. We can use the blood flow restriction. So what that's going to do is let us, it'll put a tourniquet, like a blood pressure cuff, on either the leg or the arm. It'll cut the blood flow off, and then we can set it back to anywhere from 60 to 80%. So that we're cutting that blood flow off from that limb as much as we can and then work them. And so the athlete's going to work for 8 or 10 minutes, but they're going to feel like they've worked for an hour to an hour and a half because we're turning that aerobic workout that we would typically do now into an anaerobic workout.
That's pretty cool right there. So I guess I see all of the athletes doing it now, the professional athletes. Is that kind of similar to what cupping is? Like where they... Like, I don't know exactly I just see them with all them little dots on them. I'm like, man, what in the world?
That's another example of that manual therapy. So we're bringing the blood into that area. So it's not quite the same, but similar process. We're bringing the blood flow into that area. It's going to start healing that tissue again.
Okay.
So, what are some, we touched on that. What are some of the other methods that are pretty popular in the non-operative side? Like when they do come into the CAO, or I keep saying CAO because that's what I know it as. It's the Center
for Advanced Orthopedics.
There we go. So what is some of the other things that you guys do over there?
I mean, I touched on them. So we might use some electrical stimulation on them. We might use the radio pressure wave therapy. We're in the process of getting a laser head. I mean, most of the therapists, we also do dry needling. So that's one of the things that we can really get directly into that muscle. We can hook up the electrical stim, but instead of putting a pad on the leg, we're actually putting a needle right into the muscle and getting a little bit more effectiveness out of it.
So like what don't laugh at that. I'm using the movie. Like what they were trying to do on Nutty Professor with the dude, like when they had all of the is that what it is? You know, when they had him covered in the little needles and stuff. They were basically trying to carve his appetite.
Nobody watches cartoons.
That was a movie, bro. Like Nutty Professor was a movie. But I'm saying, like, when you say like a needle, like it's kind of like I'm trying to understand it. So, like explain it to me.
These are solid needles, so there's no hole in the middle. So that the doctors and the nurses upstairs, they use a needle with a hole so that they can inject something. These are solid, and they're filaments. But I show my patients all the time. I compare it to like a fishing line, because I can literally just bend the needle over in half.
Okay.
And I'm going to stick it straight into the muscle. And if we're good, we use fewer needles. Okay. So I might put 4 to 6 needles. I'm not going to put 40 in. And then I'm going to hook some electrical stimulation up, or sometimes I might just move it around with my hands so I can wind it up, or I can piston it up and down. And we're going to get that reactiveness of the muscle that, again, it's starting a small inflammatory process so that the body's going to come back and do some healing. So after that, I'm going to tell the patient, don't go home and take some ibuprofen. Don't go home and put some ice on it. Don't do any of that for 36 hours. Put heat, use Tylenol, but let that process continue so that we can get some more healing.
So it doesn't actually puncture the skin, the needle?
Oh, yeah, it does.
Oh, it does?
But it's tiny.
Oh,
it's very tiny.
So is there blood?
Only if we hit a capillary. So I think I did a patient today. We had 6 needles, didn't bleed at all.
Okay, so this is, I mean, we're learning here. Okay, we're not.
I mean, I can show y'all. You come by the clinic.
I actually think I had it done when I had my shoulder issue not too long ago.
Stay at home.
But
It doesn't hurt.
so you're basically just speeding up the body's natural process. Like you're saying, okay, start over here.
So sometimes like I said, those athletes who are playing multiple sports year round, that tendinosis, that means it's chronic. Anytime I change it to osis, if it's tendinitis, it's new, it's fresh. The body's still doing a healing process. Tendinosis, it's been there so long, the body's forgotten. It's just thinks it's normal now. So we can bring those kiddos in and start doing some of this manual therapy and stick some needles in them, put some E-stim on them, and tell the body, oh, wait, come back and let's try again. See if we can get it a little better.
Okay, so that was a really good explanation. Like I feel educated about that.
Yeah, I do too.
What you touched about it earlier, BFR. Can you just go over that real quick and let me know what that is?
Yeah, so it's called blood flow restriction. It the first process is like putting a tourniquet either on the arm or the leg, and we're going to completely cut the blood flow off. Okay, so each patient, we're going to get a personal tourniquet pressure. So the machine's going to pump the blood, or it is going to monitor until the blood flow stops. Then it's going to give us a blood pressure, and it's going to tell us how far we should go. So then we can dial it back to 60 or 80% occlusion, and then we can have the patient exercise. So we might have them just doing straight leg raises, or we might put them on the elliptical or a recumbent stepper and have them work for 8 or 15 minutes, or maybe they're on the shuttle doing squats. But we can, again, we're turning that aerobic exercise into an anaerobic exercise by cutting off that blood flow.
Perfect. Makes sense. Okay, so again, I'm just kind of taking it all in. So Shari has given us plenty of examples of what they do inside the orthopedic gym. Or the rehab gym. What are some things that you guys do as far as the trainers, just in, I guess, like the clubhouse or the training room or something like that?
So we utilize cupping, A-stim, which is a scraping type mechanism. We also have ultrasound and E-stim units that we utilize to control that. Of course, we don't do dry needling or any other of the fancy techniques because we don't have them available to us there in the training room. But stretching, E-stim, and then
ice baths. Ice baths seem like they've become pretty popular.
Yeah, we do that also. It's usually more popular in the summertime.
Yeah.
But
I probably would rather it be in the summertime.
yes.
So I have a question, another question, and a lot of the questions I have is either I seen in a movie or I see the athletes, the professionals do it. Do y'all have at United Regionals or at any of the schools the chambers where it drops your body temp, where you get in there? It's like, you know what I'm talking about, the hydro type chambers. Do anybody in this area have y'all seen that being done?
I have not.
Yeah, because I've seen athletes, I've seen people do it. To me, it reminds me of just a fancier way of doing an ice bath. That's what I took. I was like, it's probably an expensive ice bath,
Right?
But it's just what's the theory behind, I guess, dropping your temperature? I guess from a recovery standpoint, how does that help?
It actually reduces the lactic acid in your muscles. It just gets it out of there. We use it a lot during the week, like on Wednesdays in Windthorst. We'll try to get everybody in there to do an ice bath for like 6 to 10 minutes.
And we got you here on a Wednesday.
Exactly. So they're missing out.
Uh-oh.
Yep. So,
I used to, when I was an athlete, that was my least favorite thing. And Doc, if you're watching this, don't take it personal. Doc, it was required. We call him Doc. That's what everybody probably call their trainers, but it was required. You didn't get an option, especially if you were injured. And we used to do I call it self-stim, going from hot to cold.
yeah.
That was my first time ever doing. I guess that's what it's called, self-stim. It's like stim, like creating like
Ain't
a
no
stim.
doctor.
A contrast
That's
bath.
contrast.
Yeah.
Yeah.
I mean, like, I'm learning a little
That's
something,
good.
bro.
That was
But
close.
I was close. Hey, I'm a social worker, but I got that almost right. I just didn't. My first time ever doing it, it literally shocked me because I didn't expect the feeling that going in from, and it was just really just a submerge of the ankle into the cold, going back, doing it, and I was like, what in the world is my body? But I felt like the next day I could walk on it. And then just doing that process, it just kind of helped. I feel like it's kind of some of the stuff that you guys were talking about. Just that was probably an old method back in the day.
We use that a lot back when I was in college.
Yep.
But the whole purpose of that is to pump the fluid out of that area.
Okay.
The heat vasodilates the vessels, the cold vasoconstricts it. So that pumping action pumps the fluid out of there and the swelling. So
That's pretty cool.
Very cool. Very cool. So we touched on operative and then non-operative. And once they get cleared back to play, a lot of times they probably have some, or I know that every time I go in the CAO, they send me home with home exercises, right? So I guess explain the importance of home exercises and like maybe what are some of the common home exercises that people will do for certain types of injuries.
Sure, I'll start. Actually, those athletes are going to get a home exercise program the first day they come in to see us. And same thing with Tim. If they go see him in the training room, they're going to get something that they need to be doing at home. Because if you don't have them buying into the process, then you're going to be just struggling the whole time. So if they come in and they're a knee, we're going to, especially if they're post-op, but really anytime, we're going to get them started on quad sets. We're going to get them started on range of motion on their knee. We may go distal to the issue and actually just have them do some ankle exercises just to get that limb moving, and so that they're getting it moving and they're buying into the process.
Yeah, and one thing I do want to say, because I was probably this athlete, if you don't do the home exercises, they're professionals. They're going to know. So don't lie to their face and say, yeah, I did them, when they can tell you by the way you're going to perform at that session whether or not you did home exercising.
Yes, for sure.
One of the tools that we have, Tim, is MedBridge. So our athletic trainers all have access to MedBridge. It's an online program. All of my therapy staff has access. So it's an online program that we can actually set up an exercise program for that athlete or even the patients that come into rehab. So once we give it to them, we can send it to them on their phone or their email. It'll walk them through the exercises, and we can actually tell if they've logged in and done their program. So they may be telling us, yeah, I did it. But if they can't demonstrate it back to us in that session, or if we can't see that they logged in, we know what's going on.
Well, they didn't have that back in my day. So
And that's a very useful tool, especially for like our baseball pitchers and quarterbacks. we can give them a set of rotator cuff exercises at the beginning of the season. Get after it. Here you go. And that way they kind of avoid all that tendonitis and tendinosis in the shoulder.
I mean, that's another aspect of it. If we hit it before, get their strength balanced out before, then hopefully we can avoid those injuries.
Yes.
Do you guys send a lot of, I guess for the home exercises, do you guys send bands home? I typically see the when my son was injured, that was the one thing that he did not like coming home was that band because he didn't realize the little bitty band, how strong the band was versus how strong he was at that particular time, and he didn't like having to do the exercise. And I was like, it's like, well, you got to go back. I was like, they gonna know if you've been doing what you're supposed to do. Yeah. But just seeing how the progression of the struggle of a small little band is just the struggle and how. And after a period of time, you was like, oh, I was like, this makes a whole bunch of sense.
It does. And make sure they're doing it right.
Yeah.
You know, slow and controlled and not just
fast.
Not fast. Take momentum out of it.
Yes, sir.
Knocking them out. That's why I got a band, and I was like, 1, 2, 3, 4, 5, 1, 2.
I think we gave you a red one, though.
What's that mean? The strongest one?
No.
Ouch. Wow. Okay, Miss Shari.
So that's another thing I didn't know. So there's levels to the bands.
There is. Yeah, there's different levels of resistance.
Yeah. So I mean, of course, when you see in the weight room, you know they're labeled, but I did not realize. I just thought some hospitals use. Don't nobody make fun of me for that, but thought, hey, United Regionals might use the orange one because they're orange, or
no,
like
not at all.
that's. Hey man, don't you start this time. So I literally thought it was just the bands. I didn't realize each band, the colors meant like a different strength level. So that makes sense.
So, and based on how much you stretch it, they'll actually give you a poundage that relates to, okay, this one can stretch out. If you stretch it out completely, this one's 30 pounds of resistance. So you can track it.
Interesting.
Cool.
It's crazy.
Times have changed since I was a kid, and it's
come a long way.
I love it though because resistance training wasn't a big deal when I was growing up as a kid, and I love the colleges, the high schools. A lot of people are using the resistance training. We actually talked about that with Dr. Dozier, right? I was about to mess your name up, Doc. Don't mess with me. You know he's famous, so I can't mess his name up. But he talked about the resistance, how. It helps with, the different things and building the range of motion and different things like. So I think that's pretty cool of how a rubber band is actually building the strength and making athletes better. Something simple as a band is helping out with those things. So that's pretty cool. Sure. So times have changed a lot.
And bands and using balance. So with the MedBridge program, we can show them how to do some different proprioception training.
So what?
Proprioception, that's
please.
the balance.
Okay.
That's a fancy word for balance?
Yes. I'm about to use that, bro. I was saying that to my kids. Hey, we need to work on our proprioception.
That's exactly right.
Like, what you say, coach? Balance.
So balance and body weight, like squats and lunges, stuff like that. You can send all that with the home exercise program and tell them how many to do and how long to hold it, or stretching. It's a very good tool.
Kids buy into strength and range of motion, but they don't have any idea about what proprioception is, and we have to slow them down and say, okay, if you can't stand on this leg as long as you can stand on that leg, and it's not stable, we're watching your arms move or your hips move. It has to match, and so we've got to get them to that point, and that's usually new to them. Right.
So in the training room, we use a little foam pad, and based off their sport, I'll have them stand on that pad, and I'll throw either a football to them or a softball or a baseball, and have them catch it in different angles. So,
it's pretty cool.
So, what I'm getting at here is how, they say game or sports and games are, how do they say it? A game is determined by inches or like small details, and so each one of your exercises, you were talking about range of motion, talking about being able to stabilize on one leg. I mean, it sounds like everything is so much detail oriented in what y'all do. And everything's documented to a T.
So one of the things that some of the kids never think about is if we have a kid that comes in with a shoulder injury, we might actually test their legs or if they come in with a leg injury, we may test their upper extremities just to make sure that we've covered all the bases. So one of the tests we have is called a YBT. So we might put them standing on one leg and we have them reach out as far as they can with the opposite leg to see how far they can go in the front, how far can they go over to the left, how far can they go over to the right. And then we're going to repeat that on the other side. And if it doesn't match, then we have more work to do. And even that lower extremity, that knee or hip injury, we're going to put them down on their push-up position and make them do the same thing. And they don't understand why they have to do that, but the whole body is getting a delay anytime you have an injury. So there's loss of muscle mass, there's loss of strength, there's loss of range of motion, loss of that speed and agility. So we've got to make sure that we're covering all of our bases.
So another quick question I have is there a chiropractor that is kind of teamed up with the no?
No
Okay,
chiropractor. So Dr. Oman's upstairs. He used to be a chiropractor, and then he decided to go back and become a medical doctor. So he does some manipulations because he's trained in that. But a lot of my therapists are also trained in manual manipulations. And so if the kiddo needs one of those, then we can perform that right there in the clinic.
So one-stop shop. That's what it sounds like.
Absolutely.
Very good.
So this is for you as a trainer. This is a question that's said to me. I was in college when it said, but it was a trainer. I forget what school. It was not nobody from down here. He said something to me that stuck with me forever. And it's whenever I coach in Little League and things like that, I use this all the time. He used the termination UAP. And I was like, what are you talking about? He was like UAP. It stands for Universal Athletic Position. And he said that he uses that term because when he's training and working with kids, he said it doesn't matter the sport. Pretty much every sport that you play is played out of the UAP position. And he said, so one of his philosophies were if in order for you to be ready to go back, you have to be able to play out of UAP. So he trains, and whenever he's doing rehab, he makes sure that he works with that. So I didn't know if that was like something trainers like philosophy or something, but I was like, man, that's the cleverest thing ever that I ever heard in my life.
We don't really refer to it as that, but yes, that is a very common position in all sports.
Yeah.
And if they can't hold that position or move from that position, then you need to work on some different core exercises or.
Yeah, he said, especially coming back from injuries, that's one thing that he always. And I was like, man, I've never heard that before. And he was like, it's just true. He was like, my baseball players play a certain way, football players playing a certain basketball, and he was like, those are things that I think that he was saying as a trainer that we make sure that those kids can be in those positions and move well.
Sure.
Kind of like you were saying, using the 5-10, different things like that. So
absolutely,
it's pretty cool.
All right. Well, do we have anything else, Jeremy? Is there anything else you think?
Yeah, the good-looking guy sitting to the side.
Now I'll tell you a little bit about our therapists. So we're kind of a different kind of clinic. When I hire someone, I don't look for someone who fits a little mold. I'm looking for an eclectic team. So I have one therapist who's an OCS. I have another therapist who's OCS is a orthopedic certified specialist. So she's done extra training. She's taken a test. She's certified. Then I have another therapist who is certified in manual therapy. So she has more training in specific manual therapy. So I'm looking for a group that can come together. So some of my therapists can dry needle. And so if one of the therapists is having, their athletes progressing a little slowly, they may walk over to the other therapist and say, hey, come over here and show me something different that you would do with this athlete so that we can make a little more progress. And so, again, it's the same thing as therapists working with the trainers, collaboration, teamwork across the board.
Yep.
Yeah, very good. So, Tim, is there anything else that you have? You want to touch on anything else, or might have left something out or anything? Or
Tim, talk about all the schools that we cover. Just it's a wide range.
We do have a wide range. So both of our local schools, Legacy and Memorial, and MSU, and a lot of our staff are from MSU that have gone through their athletic training program. Jeremy was also from Cameron, so we got some Oklahoma guys that come through. But we were very tied in with MSU and working with their athletic training program as well as their sports. So we have trainers at, of course, I'm at Windthorst, we have Owl Park, City View, Petrolia, Seymour, Nocona, and Wichita Christian. Yeah.
And then we
And,
cover
it's
some of Wichita
some
Falls junior high
some of their
sports as
junior high
well.
stuff. Yeah. So we got a wide
Oh, don't forget Christ Academy.
and Christ
Got
Academy.
to make
that's
sure we
right.
mention everybody.
That's a new one. Yes.
Yeah.
So yeah, we have a pretty wide range of athletic trainers. I'm probably the oldest of the staff. Actually, I am the oldest of the staff. I've been a trainer for 30 years, so I
Wow.
get called the old man a lot.
Hey, ain't nothing
Same.
wrong with that. It just means you're wise.
So I guess one thing I would say before we close out, we appreciate what you guys do. Sometimes you guys are the ones that, especially trainers and the rehab people don't understand the importance of what your job is, especially when dealing with people's children, because we're putting their livelihood in your hands, and you guys have been doing a great job. Once Jeremy told us that we were going to be kind of doing this type of stuff, I was excited just because sometimes as parents, we don't get to always ask the questions we want to ask, and then when you're living it, you're definitely not wanting to hear some of the answers that you're getting. So when you're not going through, I would call the crisis mode, because when your baby's hurt, you're in crisis mode. So sometimes it's easier to probably sit back, watch a show, and be like, man, I was doing that, and I didn't even realize they were telling me to do this, and I was stubborn. I didn't want to. And even for the athlete to, after it's over and said and done with, like understanding this is why I had to do it this way. This is why it had to go this way, because nobody wants to wait 9 to 12 months. Let's just be real, especially if you're a junior getting ready to go into your senior year, and you be like, oh, man, I don't have time. I need to be getting prepared, getting ready. But I think the time is valued. You guys are doing a great job. United Regionals, like you said, with your therapist, we can't have everybody on the show. So just the therapists and the people that are working hard in this Wichita County area to get people back and ready. So we appreciate you guys for what you guys are doing. Not just Wichita County, all our counties.
Right.
Yeah.
We're kind of behind the scene. The trainers are getting everybody ready to go, taping them. I know Jeremy and I probably tape at least an hour before the kids go out. So it's a solid hour of taping the ankles and the wrist. And it's just
These guys work endlessly. They're at the school by 5 or 6 a.m. and they may be there till 10 and then turn around and be back and do it again tomorrow. So there's a lot of endless hours that are unthanked. So thank you guys very much, because we couldn't do what we do without you being out there on the field. So
Yeah. I mean, yeah, you guys are, it sounds like every part of the puzzle is important. So you guys, everybody does a great job, and obviously United Regional is the top dog in the area at what they do.
we think so.
Yeah.
we do.
So thanks for coming on the show. I know that, I don't know, but we may have to get with you guys about, we're going to do a volleyball all-star game or a basketball all-star games. We might need to have some athletic professionals, trainers on the side. But do you guys have anything else for us?
No, I'm good.
I'm good. Thank you.
Thank you
Thanks
for
having
having
us.
us.
Yeah, no worries. Thank you guys for taking time out of your day, coming up here and chit-chatting with us. Hopefully you guys enjoyed your first podcast experience.
Sure.
And be on the lookout, because the episode will be out soon. And thank you to everybody who watched, and go ahead and share the video and get it out as much as you can. All right, we'll see you next time. See ya.